Recorded at the Southwest Conference on Botanical Medicine in April of 2016. For more information on our conferences, lecture notes, and recordings, visit our website, botanicalmedicine.org.
All men in the course of their life, nearly all of them, will have a problem with the prostate, and most men are going to have prostate cancer. This one in 6, is probably a low estimate. I think probably it's more like 1 in 3 or 4. It just depends on how long we live. If you live to be 90 years old, the chances of you having prostate cancer are very high. Most men don't make it that old, so this statistic is probably a little bit off as far as what I was saying earlier, as far as if you live long enough, you'll probably have the disease. So the way that we diagnose prostate cancer is through the biopsy. That's the primary way to diagnose it, and has been for a long time, and maintained by the Urological Association as the only definitive diagnosis for prostate cancer is the biopsy. I was just going to say something occurred to me just in the earlier talk when I was talking about testosterone and the importance of having a sufficient testosterone level in the patient, especially to prevent prostate cancer. But even in the event of having prostate cancer, maintaining sufficient testosterone levels is really important. We looked at the Gatton-Gorin stuff, and we saw that through the differential vein, you had all this testosterone flowing over into the prostate, right? Which is a problem. And so people were wondering, well, what's the story? I mean, how does this work? Does that mean the person has high testosterone or low? Or it doesn't really matter what the serum testosterone is for the patient's, the whole endocrine system, which would be measured anywhere in the blood. That level is going to be completely irrelevant compared to what gets transferred across from the testicle over to the prostate through that differential vein. So, and then I was making the point that in an 18-year-old man with the highest levels of testosterone, we don't see prostate cancer. So that's where there's a lot more to the story than just testosterone being a problem. The other thing would be that if you're giving a patient exogenous testosterone, having high testosterone is also a risk factor. So when you do get people's testosterone normalized, that's a good thing, especially if you're using the plants that we talked about earlier. But if you're using exogenous testosterone, especially in the form of creams, which are harder to regulate, harder to keep the dosing appropriate, make sure you keep an eye on those blood levels, because if you start getting supraphysiologic, now you have an increased risk of cancers, including prostate cancer. So the idea is to optimize testosterone. We go back to the slide with the Incredible Hulk and the Tai Chi Master. We want the Tai Chi Master. That guy's going to live long and be healthy. So back to what I was saying about the biopsy, the definitive test. So what is the prostate biopsy? It's basically the urologist goes in with a needle, a fine needle, and goes through the prostate gland with 12 separate cores. And the prostate's normally divided into different quadrants, left, right, primarily, with upper, mid, and lower on each side, and to go in and take a biopsy of each of those sections. And so you'll have 12 cores. And then out of those 12 cores, the doctor's trying to find out how many of those cores have cancer in them. So when they take out the material out of the fine needle aspirate and put it onto a slide, look at it under the microscope, what's there? And that's what tells you if you have cancer or not. And of course, what we want to find out if you do is that disease an aggressive form of the disease or not? And that's been one of the hardest things to determine, because just because you have prostate cancer doesn't mean you're the guy that's going to have any mortality or morbidity associated with it. Or you could be the guy who's going to die of it. It's going to quickly go to your bones or your brain. And so we don't know how to determine which one of those cases you might be. And that's where we get into problems with what is this, what is the value of the prostate biopsy. The other thing is that the prostate, compared to the size of the needle, is a pretty big area, so you can miss what you're looking for. Risk factors with biopsies, infections, bleeding, inflammation, coagulation. I mean, what are the tenets of cancer, right? We know that it's a coagulation disorder, so we know that we don't want to induce fibrosis. We don't want to induce hypercoagulation. It's got a lot of inflammatory processes associated with it. We don't want to induce inflammation. Oxidative damage is one of the problems with cancers of all kinds, so we really don't want to cause oxidative damage. And yet, with this diagnostic tool, we're doing all of those things. Not only that, but we looked at the prostate and saw the capsule of the prostate being an intact structure. Now, if you puncture the capsule, there are people who have theorized that that's not a good thing, and a lot of men come to me saying, hey, look, I don't want to biopsy my prostate. I don't want to puncture the prostate capsule with a needle and then expose that material to the tissue around it. I don't trust that process. And to me, that's a logical argument for why I wouldn't want to get a biopsy. There hasn't been anything proving that, and urologists will say, no, never happened. What's interesting now is that you have this thing right here. The MIPS is a test developed by the University of Michigan that looks at these two genes in the urine, the TMPRSS2 and the PCA3 gene, and puts them together and can predict to a very high degree of accuracy whether a man has prostate cancer based on what comes out in the urine. And this technology is being improved upon all the time. It's just not being approved yet by the FDA, and it will at some point because it's just smarter. It's a smarter way to go, to diagnose the prostate cancer without having to puncture the capsule. So when you get a prostate cancer patient now, what we're almost always looking at is we're looking at the Gleason score. The patient comes in, says, I had a biopsy, they found cancer, and I have a Gleason score. The Gleason score is a score that goes from 1 to 10, and it's the grade of the cancer. And the way that it works is the urologist looks at the slides. For each of the cores, he'll give it a grade. And the grade will have a degree of 1 to 5. And a degree of 1 is that the cells are pretty much differentiated as prostate cells. And as it progresses over to grade 5, those cells are completely undifferentiated. They don't look like prostate cancer cells at all anymore. And the more undifferentiated the cells are, the further they are from doing what they were originally designed to do and looking like they were originally designed to look, the more aggressive that phenotype is, the more likely that disease is going to spread and cause other problems. This is also true in breast cancer. It's also true in ovarian cancer. You're looking for how far has that tissue moved away from the original tissue it started from. So when a breast tissue comes up and you look at the breast cancer, if it has estrogen receptors and progesterone receptors and nothing else shows up, well, that's pretty close to a normal breast tissue, right? That's what breast tissue has. That's how it works. But when you have estrogen and progesterone receptors negative and human epidermal growth factor receptor 2, HER2 positive, you've got a more aggressive disease. So the same kind of thing is happening here. So with the grading, there's two numbers that are put together. The first number is what's the grade of the biggest percentage of the cell population that you're looking at. So if, let's say that 70% of the cells are grade 5, then you'll have a 5. And then if 30% of the cells are grade 4, you add the 5 plus the 4, and you get a Gleason score of 9. So the first number is the biggest percentage. The second number is the second largest percentage. So the grade is determined by the type of undifferentiation, and there's kind of a mark for most urologists where 7 is kind of the middle. And 7 is interesting because you could have a 7 that's a 4 plus 3, meaning, let's say the largest population of cells looked at had an undifferentiation of grade 4, and then the next largest cell population had a grade of 3. That's a 7, 4 plus 3. Okay? So it took you a 4 plus a 3 to get to 7. There could also be the 3 plus 4, where the largest population was a grade 3, and then the second largest population was a grade 4. So the first one, the 4 plus 3, is actually more aggressive. It's more into the high grade than the other 3 plus 4, which would be more in the intermediate grade. I don't know this is how it is right now, but as you see cases and you see what's happening in the field, I don't know how long this is going to stay this way, but that's how it is right now. Interesting here, we're going to talk a lot about treatment. Once you've got the disease, you've got the diagnosis, you've got the Gleason score, now you're moving forward. The first thing you're going to do, if basically in a urologist's office for most people, if you've got a Gleason score of 6 or higher, I want to take out your prostate. That's pretty much the first thing we're going to do. Probably follow it with radiation, depending on what that grade is, and potentially then put you on androgen deprivation therapy. So what happens here, you get your PSA level, it's a little bit high. Joe goes to the urologist, or he goes to his family physician. PSA is at 6.2. Normal PSA is considered anything under 4. So it's like, hey, Joe, you should go to the urologist. You got a PSA elevation. So goes to the urologist. Urologist says, yeah, we'll take a look. Let's go ahead and do a biopsy. Oh, sure, we'll just take a needle and we'll just stab your prostate 12 times and see what we find. That's the next step. So, we found cancer. A couple of those cores had, grade 6 disease in it. We should probably just get your prostate out, because this could develop into something that's a problem. And a lot of men just go right in. They go and they get robotic arm surgery. They remove their prostate, and then they suffer the consequences from that. And the idea is that you just prevented that man from being one of the men who could have developed, that disease could have developed into, frank prostate cancer that evolved into a metastatic process that had a big effect on their mortality and morbidity. Half of the newly diagnosed men have a Gleason score less than 6, and 80 to 90% of them, depending on age, undergo some form of treatment, even when the age at diagnosis is 75 years. That's in 2012. Not to say, urology is great. It's a field that's really important, but there's a fear factor that's going on in this field that is really damaging to a lot of men's health, and it's not helping us understand this disease and how to treat it. It's really pushing us towards continuing on with this, somewhat barbaric treatment that we're doing right now, which we talked about before with the Gat and Gore, and why that's not going to catch popularity is because there's a heck of a lot of money being made, and a lot of systems are in place that continue to make themselves a livelihood. They continue to go. They continue to be profitable in the realm of robotic arm surgeries, in the realm of radiation, in the realm of drugs to treat these diseases. So, again, there's a lot of different complicating factors. But fear is the one thing that I get almost invariable from every man that comes back. Is like, God, I went to the urologist. I had biopsy and I got cancer. And man, he just told me I'm going to die. I got to get my prostate out or I'm going to die, Well, that's a tough line. What are you going to do? Your doctor just told you you're going to die if you don't get your prostate out. You're probably going to get your prostate out. So what do we do about it? Well, what I like to do is consider other options, first of all, because, like I said earlier, this is a slow-growing process. Prostate cancer is not a fast disease. Very rarely does it spread quickly around the body. Very, very small percentage of men would that happen. So we have, from this urological perspective, you're going to go through your prostatectomy, your radiation, or your systemic therapy, which would be androgen deprivation. And we already talked about testosterone, right? We know that testosterone doesn't cause prostate cancer. We know that low testosterone is actually the major causative factor. There's a lot going on here. So what happens when men go through these therapies? Why am I questioning them? Why don't we just go ahead and say, hey, let's pull the prostate out. It's not a problem. It's kind of like we'll pull out the gallbladder, right? You'll still do fine. We just pull out the prostate and everything's okay. Well, me or that? Your kid? Oh, sorry. So, listening to something else. So, this was 1,600 men followed for 15 years. These are men who were diagnosed with prostate cancer, and they underwent surgery or radiation. What happened after 15 years? And what's interesting is that if you follow these guys, there's been a number of studies that followed men 10 or 15 years out who did surgery or radiation versus men who did not do that and who did watchful waiting, and the outcomes are almost the same as far as their mortality and morbidity associated with prostate cancer. But what you see here is that urinary incontinence, you've got 18.5%, 9.5% or 0.4% with radiation. Bowel urgency, 21.9% with the prostate surgery and 35.8% with radiation. These are pretty high percentages of men that are going to have problems in these areas. And the big one, erectile dysfunction, at 15 years, erectile dysfunction was nearly universal. So, if you're a 50-year-old man, you've got prostate cancer, you're going to go through one of these therapies. By age 60 to 65, that's the last time you're going to have an erection, and there's really no way around that. So, again, the consequences are serious. It's not a small thing to go through these surgeries and radiation therapies. So this is an interesting quote here. I think if a man has a low-grade prostate cancer, these data should really make him think carefully before he signs on to have any surgery or radiation, because a lot of these quality of life side effects could be avoided by choosing active surveillance. So from the urological perspective, active surveillance is basically the choice. You either just watch or you treat. But for us, as herbalists, as doctors of natural medicine, we're saying, well, no, we're going to treat you. We're just going to use conservative therapies. We're going to treat you with stress reduction. We're going to we're going to do exercise therapy. We're going to change your diet. We're going to change your lifestyle. We're going to make you the healthiest you've ever been in your life. And we're going to see how that changes what's going on in your prostate. We're also going to go after the the prostate cancer directly with our herbs and nutrients that we know will downregulate the pathways associated with that cancer growth. We're also going to monitor you carefully over time to make sure that we're not missing something, that something isn't occurring that's out of our sight, something that we should have been following. We're going to follow it closely, and we can do that. Just more here on prostatectomy. Interesting, following radical prostatectomy, death from cardiovascular diseases, other cancers, and other causes is far more common than death from prostate cancer. These men were going to die of something else, regardless of whether they got their prostate removed. Because remember I said, cardiovascular disease is the #1 cause of death. Well, I said the pathophysiology is the same. So if you don't fix the heart problem, you're doing all this work, taking out their prostate, and they die of a heart attack. They die of cardiovascular disease, So, again, if we can correct the problem, we can avoid both situations and keep the person with the quality of life. And for me personally, I don't know if everybody feels the same way, but for me, quality of life is much more important than how long I live. I'm not attached to my life in the same sense that I just got to live as long as I possibly can, no matter what. No, I actually, if life is really bad, it's really terrible, I'd like to just let go. I hope that I can do that. I feel like I'm ready. We'll see. I've watched a lot of people die. It can be okay and it can be not pretty, but I don't want to just drag it out with pain and suffering. I wanted to mention transforming growth factor beta, a really interesting test. I learned about this one from Donnie, of course. This is a test that helps you understand whether, if you did do surgery, let's say you've got a guy who's got an aggressive disease, let's say almost all of his cores came back positive and he's got a high Gleason score, he's really worried about this prostate cancer, what are we going to do? Well, the surgery is an option, but if he has a very high TGF-beta-1 level, pre-surgery, his risk of having disease progression after surgery is high. And you can look at that. You can actually say, whoa, let's wait. Your TGF-beta-1's at 12,000. It should be under 2,000. Let's consider, because if you take your prostate out right now, that disease is going to spread, and possibly more rapidly. A lot of cancers are under control from non-metastatic proteins. Non-metastatic proteins that are secreted by the primary tumor that inhibit circulating tumor cells and endothelial cells, which are in the bloodstream, from planting in other tissues. We have this as the same mechanism in our bodies. We have cells from our organs that are nestled in other areas, but they're under inhibition. They're not going to just start growing somewhere else. It's the same mechanism inside the cancer that's saying, as long as the primary tumor is the focal point of growth of the disease, don't go out and spread and seed other areas. Everything's okay right here. We're growing right here. You take the primary tumor out, and then suddenly, boom, disease spreads. When I was doing a bunch of work with Donnie, doing teachings on surgery and cancer, I started digging in the research, and the way that they would induce stage 4 disease in rats was they would take a tumor type that they'd already frozen, and they'd know that this tumor they could culture, and it's a tumor that would act very aggressively. They knew it was an aggressive form of disease. They would inject it into the rodent would have the tumor, they'd let it sit for 3 weeks, let it grow, then they'd yank out the primary tumor. You know what happened? It would spread all over their body. That's how they created the disease in the animal. There's the papers are. It's just look at the materials and methods. So radiation is one of those treatments that's just it's hard for me to even understand. Its place in medicine is hopefully becoming smaller and smaller because it's such a damaging therapy. Ionizing radiation is really powerful. It's intense. Right now, because we haven't focused on other things, because always we get entrenched in doing something a certain way, and then we do it that way because we have all the tools to do that, but we can't get ourselves out of it and do something that's maybe better, even though there are better options. We're kind of stuck like that right now. Hospitalization, 22% of men after radiation, and it's an interesting thing. Men you get scared and you're like, geez, I just need to radiate my prostate, and then they go through it. It's intense, and the side effects are very real. So I mentioned androgen deprivation therapy. This is this was like kind of the standard of care. I watched my grandfather die within 9 years of being on triple hormone blockage after being like such a robust 81-year-old. But when you take away the hormones in a aged man or woman, you can't rebuild. We talked about at length, right? Anabolism is about rebuilding your own tissues. So what these drugs do, and the chief one here, Lupron. Lupron is a gonadotropic releasing hormone agonist. Okay, Gonadotropic releasing hormone comes from your pituitary gland. What Lupron does is it stimulates the production of luteinizing hormone from your pituitary gland that then increases the output of testosterone from the testes to such a huge degree that the rebound effect shuts down the pituitary for a length of time. Normally the injection is a 6-month injection. So you give yourself the injection, it agonizes the pituitary, you make all this luteinizing hormone, you get this big burst of testosterone, and then it all shuts down. And you don't make any more testosterone for the next 6 months. That's the therapy. Well, guys, didn't we just spend all that time studying testosterone and how important it is for health? How important it is to get testosterone levels normalized? It's just such an odd thing, you know. And what they have to do is the Casodex is a testosterone receptor antagonist. So they give that drug for the first 2 weeks after you get the Lupron shot, because when you get that burst of testosterone, well, geez, you just flooded your body with a ton of testosterone, and if you're over-converting to dihydrotestosterone, you're going to get a lot of dihydrotestosterone, and if you've got cancer, it can promote the cancer, especially if it's metastatic disease. Then Avodart we talked about, and Avodart is the 5-alpha reductase inhibitor that's going to block the conversion, so they put that drug in there as well, so that any testosterone that's around at all can't become dihydrotestosterone. 500,000 men are treated with GnRH agonist annually in the United States. Wow, it's a lot of men. So just to look at some of the effects of hormone depletion, I mean, we just take what we learned about how positive testosterone is, and then we just take the opposite, right? The heart muscle starts to fail, neurological decline starts to happen, atherosclerosis, increased inflammation, oxidative damage goes up, everything starts to fall apart. And men are put on these drugs, unfortunately, for long periods of time, and I think there's just some people who are just sort of naive as to really what's the benefit versus what's the deficit when you give somebody one of these drugs for over a long period of time. And I've watched people just suffer needlessly because there's better ways of doing it. A newer drug called Degarelix just came out. This is a drug that doesn't increase the testosterone surge. So if you got someone doing Lupron and they're going to do it, well, get them on Degarelix because it's a brand new thing and it works better. It's got better outcomes and it doesn't have the big testosterone surge up front. It's still going to have the problem. You're still going to have the no testosterone and no estrogen. This is why in breast cancer, when women have a estrogen-positive breast cancer, they'll also be put on Lupron because it inhibits estrogen as well. I put here that you still need to implement intermittent therapy. So one of the things that was really interesting about androgen deprivation is that it was found that if you take androgen deprivation therapy drugs just for a period of time, like you do it for 6 months, then you stop. Then you let your body recover for 6 months. Then you do it again. Then you stop. And maybe you do it again and then you stop for a year or two. That it's the same benefits. The outcome is the same. The nice thing is that when you do that, you actually give the person a little bit of a chance to recover. It's not just a complete suppression of their ability to rebuild their tissues over a long period of time. Of course, from the oncologist's perspective, it's like, look, I'm not letting my patient die of cancer. That's the number one goal. And I've got a lot of oncologists that I know who say the rule in oncology is to overtreat. You overtreat the patient because you don't want them to die of cancer. Well, that's I can understand that, but that gets back to the fear, and that gets back to the other downside of the overtreatment. This is just newer studies looking at the fact that we don't really see enough benefit with ADT. We shouldn't be using this. It should really only be there to palliate symptoms or prevent imminent symptoms associated with disease progression. Mostly this is in diseases that are hormone positive, androgen receptor positive, that need to be shut down because it's already in the bones or it's in the brains, it's already moved along, and we need to do something drastic right now because herbs aren't going to get this person well. That can happen. People come in with a very aggressive disease, you need to do something, and that's when these drugs could be indicated. Side effects, you can imagine what they are. Hot flashes, sexual dysfunction. I mean, there's no erection is going to happen at all. Can't build any muscle. Everything just starts to break down. Metabolic syndrome, weight gain, depression is a big one. So one of the things I wanted to say is that with the environmental pressure, if you have a cancer, and it doesn't matter where it is, if it's prostate cancer or another cancer, and it has a growth factor associated with its progression, and you just target that one growth factor and you stop that growth factor entirely, well, it's just like in nature, just like anything, just like any living system. If you give it enough of a strong environmental pressure, what does it do? It adapts, right? It changes. And that's what happens with cancer. That's why the whole targeted therapy approach to cancer is failing. That's why when we got a new drug for melanoma that targets the growth factor that we associate with melanoma, the KRAS gene, doesn't work because people get well for 3 months and then, disease is back all over your body because now it's a new version of that cell that doesn't respond to that therapy. Same thing happens in lung cancer. New drug comes out, it targets the epidermal growth factor receptor. Boom, 2 months, it's regressing, yay, and then, wait, it's everywhere. This happens over and over again. So again, it's strong environmental pressures lead to mutational changes. So we want multitasking. That's why herbs are so good. They multitask. They hit lots of different areas. It's like a Donnie phrase, multitasking. So I talked about biomarkers before, some specific ones for prostate cancer. On the left side there on the column, the second one down, PAP, is called prostatic acid phosphatase. That was the original test for identifying prostate cancer before the PSA was developed. And the prostatic acid phosphatase is a great test. It's just that it's not good enough alone to tell you enough information. It's much more specific for prostate cancer. It's not going to go up if you've got a fungal infection or you've got a bacterial prostatitis. It's not going to rise the PAP. It'll affect the PSA because the PSA is non-specific. But the PAP is very specific for cancer. And if you see that PAP start rising, you know that the cancer is on the move. It's a good indication that something's happening. That's why I like that test. CEA, that's a general marker for cancer. And in prostate cancer, carcinogenic embryonic antigen is a marker of disease aggression, aggressiveness of the disease. So if you measure a CEA in a guy with prostate cancer and it comes back at 12, well, that guy's got an aggressive prostate cancer, most likely. It's one marker. Chromogranin A and neurospecific enolase, those next two tests, those are both tests that you run on prostate cancer patients as well to determine if it's a neuroendocrine type of tumor. And neuroendocrine type of tumors are more aggressive type of tumors. They're often diseases that we have to be a little bit more considerate of the aggressive action of the disease when we make our choices. CTC, that's the circulating tumor cell analysis from Cell Search. It's FDA approved now for prostate cancer, breast cancer, and colon cancer. It's well covered by insurance. I think in some states naturopathic physicians can order that test. That is a good test. It will normally not show up until the cancer is big enough that it's sending out a lot of seeds. When cancers get large enough, they start to seed the rest of the body with circulating cells. They're called circulating tumor cells. And what this test does is it puts a little nanoprobe on it's got a little nanoprobe that it runs the blood of the patient across, and that probe has little teeny, hundreds of little metal probes that are like nano-sized that pick up certain proteins, cytokeratins. And the certain cytokeratins that it's designed to pick up are ones that are found in the cancers that we're looking at. And in some cases, even with organ-confined disease in prostate cancer, you can find circulating tumor cell numbers that are above normal. So a normal CTC is 0 to 5. If you pick up anything above that, this guy, if you take out the prostate, you missed the cells that were circulating. So it's a good thing to know up front, does this person have circulating tumor cells that are identifiable? And if they do, how does that change your choices? And it should change your choices. PCA3, that's part of that MIPS. This is a test developed by Steve Bostwick. He's a urologist down in this part of the country. Actually, he's got a number of labs around the country now. PCA3 is a really good urine test that shows you prostate cancer really specifically. It looks for prostate cancer, and it's a very good test. The research behind it correlated it with biopsies and found very high percentages, 85 to 95% accuracy with the PCA3 test. It's a good test to have. And a lot of these tests, I just keep running them with my patients because I want to know how are things going over time. I've got guys that have been with me for 10 years. I've got one guy who's been with me for 8.5 years. His name's Richard, and he has had a PSA, when he came to me, a PSA of 35. He's never had a biopsy, did a color Doppler. It came back equivocal. It was sort of hard to tell. He has no urinary symptoms. He's never done a biopsy. He doesn't want to do it. His PSA has been anywhere between 90 and 35 in the past 8.5 years. And I've been just following him. And I watch his PAP, I watch his PSA, we watch his chromogranin A. His CEA sometimes changes a little bit. But it shouldn't happen, right? I mean, that's just, a PSA over 4, you're going in for surgery. So just to say that there's a lot more going on here. Like I've been saying before, there's a lot of things that are coming up in this talk hopefully help us think a little deeper about what's going on. Prostate cancer likes to go to the bone, right? You guys know that? And it's not a lytic lesion like a breast cancer lesion is. It's a blastic lesion. The osteoblasts are over-proliferating on the bone. So it responds better to certain therapies, especially from the drug therapy realm. A lot of guys will come to you with bony disease. And if you're watching someone over time and they're doing active surveillance and, they're doing our natural treatments, let's say, and you want to keep an eye on things, you can look at their alkaline phosphatase, which you might think of as a liver enzyme. But alkaline phosphatase actually has 3 different fractions. One of them comes from the liver, one of them comes from the bone, and one of them comes from the intestines. And you can actually order an isoenzyme test that will take the alkaline phosphatase and divide it into the percentage of that molecule that's coming from each of the different organs. So you look at the percentage of it coming from the bone, and that'll tell you an idea of where is, because if a person has an alkaline phosphatase, it might be normal, but if 85% of it's coming from the bone, that tells me something's going on. If it's elevated, we don't just say, oh, it's a liver problem. We say, well, how much of it's coming from the bone? Then you look at the tandem R ostase, which is the bone-specific alkaline phosphatase, and that's another marker that will tell you how much bone turnover activity is happening. And high rates of bone turnover are associated with bone metastases. N-telopeptide and C-telopeptides, these are also urinary tests that can help you tell bone turnover again. They'll both be helpful for finding out how much bone is being remodeled. And too much bone remodeling makes me go, is there something going on in the bone here that we're missing? Bone imaging, that's a technetium 99 bone scan. That's a nuclear medicine scan. That's kind of like the standard of care, but it's nuclear medicine. The F18 PET, that's the fluorodeoxyglucose test. PET CT, that's probably the gold standard for looking at the whole body, see the bones, see the tissue. You can't see soft tissue very well, but you can see anything hard. And it'll pick up the bone lesions really nicely too. And then my favorite test for follow-up every couple of years with guys who are long-term following a program where they didn't want to start with prostatectomy or radiation is to do the endorectal coil MRI. It's not a fun test because it's literally a coil that's inserted rectally and then it's blown up. And then that becomes the centerpiece of the magnetic interface with the machine, the MRI machine. But it gives you a very clear image of the whole pelvis. So images the seminal vesicles, all the lymph nodes of the pelvis, the prostate, the bony structures. And a lot of times if the prostate's going to, it's going to grow, it's going to extend from the primary lesion outward. So a lot of times you get lymph node involvement or you get extensions into the seminal vesicles. We saw how the vesicles were right there, right? The transitional zone has the seminal vesicles coming right into it. The prostate cancer can grow that way. And just a side note is that cancer, prostate cancer, just being one of many, cancer will grow in that fashion anywhere in the body. 3 different ways that it can spread. One is just it extends, it spiculates, and it grows outward from its central primary tumor and just grows into the tissue around it and invades as a space-occupying lesion. Second, it goes into the lymph system, and it moves through the lymph network and becomes in the lymph nodes where you can see hardnesses and swellings into the lymph system. The third way is it goes into the bloodstream, like we said before, like the circulating tumor cells, circulating endothelial cells. Okay? So we want to try and monitor all of those possible ways that cancer can spread. The guy who found the PSA test, the guy who developed it, Richard Ablin, he's come out and spoken out against his own test. He hates it. He thinks it's been abused. He's got a great chat online. He's got, like Richard Ablin has his own PSA chat. It's really cool because he'll go through his whole, he just basically says, guys, I never meant this test to be this way. And there's a big debate in urology right now about, do we screen everybody for PSA? Should we do that? Because we're finding a lot of guys have PSA elevations with a test that's not specific, and we're going in and we're treating them really quickly for, we found a little bit of cancer, let's take out their prostate. He's saying, wait a minute, guys, 85% of those guys aren't going to have any problem with their prostate, even though they've got a little bit of cancer. It's a slow-growing thing. It's going to take a long time, and most guys will die with the disease and not of it. That's the important part of it. So he's been really like, guys, stop testing everybody with PSA. Other thing is it's one of many markers. That little sheet I gave you with the PSA specific markers, look at all those markers. Then PSA can make sense. Just as a one test out in the clear, it doesn't really help us. I talked before about how it's highly sensitive, highly specific, but how it's highly sensitive but not highly specific. It's not specific for prostate cancer. That's the problem. This is just a little example of a patient who could have a PSA of 10. Their prostate could be any one of these sizes. Right? The same guy. So prostate sensitivity to PSA is unique and individual among different people. So one guy can have a PSA of 10, and his prostate could be swollen. He could have disease into his lymph nodes. Another guy could have a PSA of 50, and his prostate's barely enlarged. Oh, TGF-beta 1? Molds? Yeah, it's actually used in molds and Lyme disease. A lot of infections, sort of deeper infections. In this case, it's correlated directly with disease spread. So it's more associated with the occurrence of metastatic disease after surgery. Yeah, thanks for the question. Okay, looks like we made it through that stuff. Okay, botanical medicine. I like this slide because it gives me... Yeah, go ahead.
Do you recommend any screening for an annual exam for a man over 50? A rectal exam, or is there any screening test that you recommend?
I mean, DREs are great. Like I said, I don't really think that we should all be getting a PSA screening at 50 years old. It's interesting because like the guy I was describing who's been with me 8.5 years, he doesn't have any symptoms. He's got an elevated PSA. He would have gone through whatever processes. You can see on his MRI, his endorectal coils, he definitely has a tumor, but it's stable. It's been stable for 5 years. PSA? Yeah, the free PSA will go down as your risk of prostate cancer goes up. If you have an infectious problem that's like a prostatitis, the free PSA will be high. So if you get a high PSA reading and the free PSA is high, that's probably not cancer. The lower the PSA, the free percentage is, the more likely it's cancer. As far as your question goes, I think the DRA is good, but remember the DRA only touches the back end of the peripheral zone. It doesn't really get you to the transitional zone until the tumor's a little larger, so it still misses things. I just like to have people do more of a thorough overview, keep them healthy, look at their blood work. If you're doing PSA screening, just make sure you're looking at a lot of other stuff too. Make sure, we saw that the whole prostate biomarker page that I've got. That's the kind of stuff I like to look at. So traditional medicine guiding us on our road to uncovering what we can do with plants. I know that Kenneth was talking about this earlier, just the importance of traditional medicine, following some traditions, the idea that, hey, we've had this plants here for 2,000 years, they've been used to treat these diseases, but we don't have any clinical studies, so it's all a bunch of BS. Get rid of it. We're not going to use it. And I don't believe that. I actually think that traditional usage is the first place I go. Someone says to me, oh, what about this plant? What do you think? And I'll say, well, I don't know. Has it been used? Does it have a traditional usage? Does it have a history? Does it have a folkloric use or a medical system that applies it? If not, then I'm already skeptical. If there's data to support it, great. But who's going to pay $5 million for a phase 3 trial to validate that ginseng is really good for blood sugar? Who's going to benefit from that? Where do you recoup the $5 million? Are there other cancers? Oh, I'm sorry, what?
For instance, applicable to the same scenario that you see in prostate cancer. In other words,
oh, right. So I think what you're asking is can we take what I'm talking about with prostate cancer and apply it to other cancers? And the answer is no. Yeah. Yeah, and cancer is really 1,000 diseases. Glioblastoma is a very different thing than an ovarian cancer, a very different thing than a breast cancer, very different thing than a squamous cell cancer versus a melanoma. They've got it goes on and on. They're very unique, and each one needs to be picked out individually. Question?
Can you adjust or work with botanicals and molecular targets in other cancers, or well, actually, what I discussed
Yeah, and I think it is. And that's, yeah. Thanks for clarifying. Yeah, that definitely with breast cancer, with mammographies, there's been another kind of one of those big questions. Should we be doing this? How many women are being treated for tumors that might have regressed? Because there was a big study that came out of Scandinavia that showed that 20% of the women that were diagnosed with tumors that were on not biopsy but found on mammogram, 20% of them just went away. How do we understand who the person is and what's going on? So we need to understand the phenotype of the person. So again, if I got a guy coming in and he's 45 and he's a strong businessman and he's really powerful and he's got a prostate cancer, it's more likely he's going to have an aggressive kind of disease than an 85-year-old guy who's really just weak and kind of crawling around. It's going to be two different things. I can't say for sure, but definitely that's what I'm going to be thinking. I'm going to be thinking, wow, this guy who's 45 has got a lot of hormones in his body, a lot of growth factors, a lot of energy. That cancer could really capitalize on that and be aggressive as well. So botanical medicine, that's why we're here. Key botanicals in benign prostatic hyperplasia. I just threw up some of the kind of more common stuff. Ginseng, I want to talk about first because it's just got so many uses. Like I said, the Taoist proverb is everybody over 35, every male over 35 should be taking ginseng. We know that our hormone levels start to decline at 35, and we know that ginseng is going to do a great job of helping us stabilize hormone levels. It's going to increase receptor efficiency. Not only will it help you produce more anabolic compounds, but it'll help those anabolic compounds interact more efficiently with the tissues they're targeting. And that's a really cool thing about plants, is that it's not just like giving the hormone. The plants actually help to influence how the hormone's used, how the hormone's metabolized. And like Kenneth was saying before too, it's the saponins in this plant, or the ginsenosides, which are the powerful components. They're soapy-like molecules that have a big impact on absorption of other things. That helps to kind of emulsify things in the digestive tract. Ginseng has been notoriously known as something that targets a Chinese concept called the source qi. And there's no other plant that targets the source qi, okay? There's the essence, which we've talked about, and we have tonics that tonify the essence. And for deficient people, it's great to tonify their essence. And I want to make sure that, when we're looking at this stuff, these are just things that are specific for the prostate. Like yesterday, I talked about things that were specific for the heart. But on the whole, we want to treat the whole person, right? Tonify the deficiencies, reduce the excesses, get rid of the pathological factors, support them where they're weak. That's the basic concepts. And I went through those 8 principles yesterday. Simple principles. But so ginseng, although it does have that stimulatory effect on some people, when the research was being done on adaptogens in Russia, they were looking for a plant that would help to extend people's ability to focus under duress, in periods of stress. Well, we could just apply that to our lives. We've talked about, before. You're driving in your car, you're pissed off the person didn't turn on their turn signal. You're upset about the argument you got in with your partner. You got, something happened at work. There's a constant stress going on, this constant pattern of beta-adrenergic stimulation happening that's pushing tissues to change. It's changing the way your heart beats. And like I said, the heart-prostate connection, it's changing the way the tissue in the prostate's responding. So ginseng and other adaptogens will help us adapt to that stress and help the tissues not respond in a negative way to the way that we're going through the stress in our life. And this plant has the potential of, to stimulate some people because it's warm. But in general, I find this plant to be really well tolerated. And that's just me. That's just the way that I practice. And maybe I influence the way that I'm doing it because I combine it with other plants that make it more palatable for some people. You can use other ginsengs as well. There's American ginseng, which is cooling in nature, which has a lot of the same ginsenosides, plus some other ginsenosides as well. There's a red version of this Panax ginseng and a white version. The white version is a little bit cooler than the red version. But the red version is really the most powerful form of ginseng, the Korean ginseng. Look at all the things that it's done. Traditionally, it's been shown to tranquilize the mind, calm the nerves. And we're talking about a plant that induces anabolic activity, right? It's building, it's strengthening, it's warming, it's yang, but it's calming also. Some formulas will put this plant in as a sleep aid. One of the great sleep formulas, Gui Pi Wan, bolster the spleen decoction, has ginseng. And you give it to people before they go to bed. For the right person, it does the right thing. We can't just give the prescriber tradition of give everybody ginseng because it's great, or give this guy ginseng because we know it's going to be good for his disease. We want to give it to him because it fits his constitution. Improving memory, that's another thing. Again, when we get back to insulin, inflammation, regulation of the HPA axis, all these things are going to affect neurological function, endocrine function as a whole. I don't want to go too deep into it, but dosing Panax ginseng for people, I normally put it inside of a formula. It can be a chief herb, meaning it's kind of like the directing force of the formula, but then you combine it with other herbs. It is considered an adaptogen, but in Chinese medicine, we don't use the term adaptogens. We just use the term herbs, and we use herbs for people specifically. I think adaptogens is a nice way for people to go, hey, I don't really know exactly what each of these plants does, but I know that they're all pretty much adaptogens, so they generally are going to be good for people. And it's good. It's a convention that helps people get herbs, but it doesn't help us be more scholarly and astute about applying the herbs more specifically and individually to people. So it is an adaptogen in that way, but it's a warming herb that targets the source qi, which is the place where the essence of the body is becoming the qi, where the essence, where the material to make you every day, what becomes your hormones, what becomes DHEA, what becomes cortisol, what becomes your neurotransmitters, all that material has to interact with the body at this key place where it moves from being this amorphous essence into being a formed structure. And that point is considered the source qi point. And that's where ginseng will act. And that's profound because, like I said, there's no other plant has ever been given that quality to influence the body at that level and direct function. And that's what we get to with these plants is directing function, directing enzyme function is what we want to do. And this plant is not going to end up promoting cancer. People often say, oh, I can't take ginseng, I've got prostate cancer. Like, well, all the research we have on ginseng says that it inhibits prostate cancer. Anti-proliferative activity against human prostate cancer. It's a cell line. Most of these studies, again, we don't have the human data. And that's the big critique of Western medicine against what we do. But come on, guys. We need another system. We need another way to validate our therapies and our approach. We don't fit the model of randomized, placebo-controlled, double-blinded studies. That's not going to work for us. So how do we get through this? That's something that hopefully will work out while we're still alive. 500 scientific papers published on this herb alone. So let's go into something that everybody knows about. Serenoa repens, saw palmetto. Everybody knows this plant and thinks about it. Oh, it's great for the prostate. There's been some kind of like back and forth about, does it work, does it not work, is it good for BPH, is it not? Again, I want to say that this plant is really good as a reproductive system tonic for both men and women. It's great for women who the reproductive organs are small. Both people. Just when there's not a lot of energy in the reproductive system, it helps to tonify the reproductive system. It also has been shown to do things allopathically and in a biomedical context that we can correlate with the prostate cancer problem. Definitely need that high fatty acid concentration. We want to make sure that whatever you're using is an extract that is at least 85% fatty acids. If it's not going to be as potent. The liquid supplements are the way to go. It should be gel caps, so it should be in an oil. So we know from both clinical experience and from research that long-term treatment is going to reduce the urinary symptoms. We talked about lower urinary tract syndrome, LUTS. It's great for that. It really does help in a lot of people. But again, it's not the right thing for everybody. It's just that a lot of men with BPH, we described the phenotype before. We went into the turbidity, we went into the dampness, we talked about the change in the estrogen to testosterone ratio, we talked about adiposity, we talked about the sedentary lifestyle, the lack of exercise. All those things lead to this deficiency and this weakness in the reproductive system. This herb will help. We still got to do all those other things, but this is a great way to get after it and start to make changes and tonify that system. It will help to reduce the symptoms in the benign prostatic hyperplasia. They did some studies too on, it's the International Index of Erectile Function, and it's been shown, Serenoa, to improve that outcome in patients. Just a couple more studies for you guys if you want to do a little digging. Saw palmetto, it has this, it has this reputation, and a lot of times I find that things that become not anecdotal, what's the word I'm looking for? They become trends, fads, they become What's the word? Household? No. Things that often get really famous and get really popular and people all jump on the bandwagon and say this thing is so great, it's probably because at one point they were good. Like they actually worked. There's probably a reason. What's that? Trendy. Trendy's a good word. Trendy. There's another word. Maybe Ken, you know what word I'm talking about. Chic.
Is that it?
That's so cool. That is not the word, but that's really cool. Okay, let's talk about nettles. So people think about nettles. You always think about the nettles, as this nutrifying plant. It's an incredible plant. I grew up in my backyard. I love it. I eat the leaves all the time. But we're not talking about the leaves here. We're really talking about the root, okay? And it has shown benefits in BPH, decreases the prostate volume, increases quality of life. The dosing is pretty important, and you need to get the dosage up high enough. What it does, too, is it modulates what we talked about earlier, sex hormone binding globulin, right? It has a direct inhibitory effect on SHBG. People talk about this a lot, and I find that if people don't get the dosage right, it doesn't work. So you've got to push the dosage up until you get the effect that you're looking for. The phytosterols, beta-cytosterol, we're going to talk about that as an individual compound. Cytosterol, beta-glucoside, these are all really good. It's good for both prostate cancer and for BPH. 1 to 3 grams per day as a single agent. And I use it in a powder. I do the same thing as Kenneth does. I get a lot of powders in my clinic, and I'd use them. I buy them by the kilogram or 5 kilogram bulk, and then I'm able to bottle them myself and give them as powders to people. And if they don't taste great, you put them in a little bit of coconut milk, you blend them with some berries, and you make them a really nice shake that's delicious. And they can get their powders, and they can get doses that are actually physiological. Otherwise, you're taking how many capsules? I mean, I have patients that I don't want to take any powders. Suddenly they're doing 120 capsules, and then they're telling you they've got pill fatigue, major pill fatigue. And it's a really big issue. But if you can get it into them in these powders, man, the dosages are higher, the fatigue is way lower, it's much easier to get them in there. And people often do a smoothie in the morning, put their powders in there, mix it up. You can use yacon syrup, you can use molasses, you can use some stevia or lohan if they're not averse to those those flavors, whatever they need to make it taste good. Putting things in there like glycine that tastes good, things like theanine if they need that tastes good. Mix and get a nice blend going and make 2 or 3 smoothies a day. Double or triple your doses, put the stuff in the fridge, and then have your second dose in the afternoon of your smoothie. Now you're getting your protein, you're getting your fats, and you're getting your medicine all together. And oftentimes, when we put the formulas together, you take an herb like nettles, you combine it with saw palmetto, you combine it with something like Pygeum africanum, you start to use lower amounts of each individual substance. And the idea often is that you get synergy between the different substances because they all kind of go towards the same domain. But I'll say in some cases, remember, it's important to dose high enough with an herb that you get a physiological effect of that herb. Sometimes just putting them together and hoping for synergy doesn't give you the results that you want. Sometimes it does, though. And if you're doing, I think in the preventive realm, where you're trying to prevent disease, it's great. A lot of people out there, a lot of companies have really cool formulas. I'm not big on patented formulas, but for people, they want something simple. A good gel cap that contains an oil base of a lot of these supplements together, these herbs, can be really helpful. Pygeum, 300 milligrams 3 times a day. You want to have 25% sterols. Again, plant sterols. We've been talking a lot about sterols. These are plant compounds that the plant uses to rebuild its tissue. That's what it's going to do in our bodies. It just doesn't have as strong of an affinity as our anabolic hormones, but that's cool too because it won't compete with our hormones. So this is the cucurbita pepo. We have the pumpkin seed. Pumpkin seeds are interesting because I always tell my patients who have GI problems or if we have an inflammation, any kind of itis, and they're like, what's going on? I can't figure it out. I do a big dietary thing. I mean, most of my patients, first thing, we're going to just get your diet straightened out. And sometimes you got to be careful. You got to go slow. Some people are real sensitive. But a lot of times, if the person looks like they're ready to warrior up and get their situation straightened out, I'm going to pull them off of sugar, wheat, dairy, corn, soy, nuts, seeds, chips, popcorn, cocoa, caffeine, alcohol, nicotine, oats, sometimes eggs. People are like, whoa, my God. But I'll tell you guys, it can be huge how much of an impact you can have on a patient's outcome if you just get them eating the right foods and not eating the wrong foods. It's great when the person comes to you and says, well, what can I eat? That's the book that we need to write. What can I eat? That's the perfect thing. It's like you give the people what they can eat. It's much easier to tell them what they can eat. It's just that simple list of foods. But it does wonders. And pumpkin seed is one of those things that I often say, don't eat seeds like this. Because when you chew up these seeds and you digest them, or you eat them and you swallow them, they go through the stomach into the small intestine, these little particles are hard to digest for some people. And when you're having sluggish digestion and you already have irritation and inflammation, seeds like this, things like almonds, things like cashews, seeds like this and sunflower seeds, I often say, hey, we're going to hold off on those for a while until we get the inflammation calmed down. Even things like cocoa. These things can irritate. The ileocecal valve is a place in the digestive tract where there's a small valve between the ileum and the cecum. And that valve is really tightly controlled, and it's soft, juicy tissue there that's tight. It's what's opening and closing, allowing the feces to move from its final absorption in the ileum into the cecum, where it's going to be packaged for removal. And that place can be really irritated. The tissue can be irritated by popcorn, for example. The little pieces of popcorn are really hard. It's like chitin. It's like really a hard material that doesn't break down well, and these tiny little particles can be irritating, especially if the tissue is already really inflamed. For most of us, it's okay. Like, I can eat popcorn. It's not a problem. But when I was in really severe pain and I needed to get myself out of it and nobody could help me, I finally got myself straightened out by getting my diet cleared up and getting all these things out of the way. My inflammation went away instantly, and I was cured. It was amazing. I had done prolotherapy and every kind of thing I could do, every acupuncture, chiropractic, everything. So for some people, getting the right dietary stuff together is going to be the most important thing. And I don't want to discredit pumpkin seeds. I'm just saying that I don't have people eat huge amounts of pumpkin seed. I'll use an extract again of this compound that has a lot of the delta-7 styrene in it that will have a good interface with the other plants that we were just talking about, because it will help to inhibit dihydrotestosterone. And what we like to see with these plants is that they modulate dihydrotestosterone. As I said with the Avodart and Proscar, they inhibit the 5-alpha reductase enzyme very entirely. They just block it completely, so whenever they can interact with it, they're going to stop the conversion of testosterone to dihydrotestosterone. Plants are going to modulate the enzyme and work with it. It's a good thing to think about, because down the road, past the conversion of testosterone to dihydrotestosterone, is another conversion that's called androstenediol alpha and beta. And those two metabolites have effects on the endocrine system too. And androstenediol beta actually has a protective effect. So we don't want to take away all the DHT because we miss this other part of the metabolic process. So I just put this one up here. You guys didn't get this one in your slide, but I want to put a TCM formula. This is a formula that would be for that kind of deficient type. These plants, Wu Yao, the Radix lindera, Ijiren, the Fructus alpinea, and Dioscorea shanyao, put together as a way to really strengthen, warm, and firm up the lower jiao, what we call it. And that's that gate. If we went back to the dam idea, we want the function of the prostate and the bladder muscle to work really efficiently. This is a really cool formula. Shut the sluice. This is for all these kind of, a lot of nocturia, a lot of frequent urgent urination, dribbling. This is like weakness in that tissue. The tissue is flaccid, flabby. It's starting to it's not working appropriately. This is a really good formula. But again, if this is for a person with kidney yang deficiency, spleen and kidney yang deficiency, this is not the person who has really severe liver qi stagnation with a liver yang rising, hypertension, real excited and red and angry. That person needs to be cooled down. And this is not their formula. Prostate cancer botanicals are a little bit different. Milk thistle, one of my top herbs for prostate cancer. If you didn't know that, it's one of my top ones. And I dose it again. I get it as a powder. It doesn't mix in water. So don't tell your patient to take a teaspoon of it and put it in a glass of water and mix it up. It won't work. But you can get teaspoon doses of milk thistle at a really great price. It works great in oil. It goes into any kind of lipid. So coconut milk works great. It's a great way to mix it in and have people take it that way. I sit around in my office all the time up in my dispensary, and I'll just play with. I'll get a new compound, and what does it mix in? Mixes in alcohol. Oh, we can put it with your tincture. Oh, it mixes in water. Great. I love things that mix in water. Or mixes in lipids. It's really good to know these things, because I also like to do powders. You can get bigger doses. 1 to 3 grams a day, that's pretty conservative. Someone might do a half a teaspoon in the morning in their smoothie and a half a teaspoon before bed. That's a really good dose of milk thistle. Milk thistle has shown, there's just the amount of areas that it has affected cancer positively is pretty amazing. Silymarin which is really these 4 flavonoids, silibinin, isosilibinin, psilocybin, and silicrystine. These are all compounds that together have a net effect of that flavonoid protection in the body. And this herb has a lot of historical usage as a hepatoprotective herb as well. It's used for liver ailments. So we know it's got traditional usage, and then we can see the data as well. You can just see, here's a few of the areas that milk thistle inhibits pathways or modulates pathways associated with cancer progression. Prostate cancer, well, I'm just going to say one other thing about the liver. The liver channel in Chinese medicine actually circles the genitals. And like I said before, liver stagnation, if you couple that with that spleen deficiency and dampness picture, now you're seeing most American people. And where's that liver qi stagnation coming from? We talked about it. It's the anger. It's the inability to get out the frustration with the stresses of life. And then sitting all day long is not helping. Not only is it leading to all that vascular insufficiency stuff that we saw before, but it's also contributing to a lack of flow through the liver. And the liver's job is to create free-flowing energy throughout the whole body, to extend to the periphery. The liver is happiest when you feel great, when you're really excited and feeling good, your fingers and your toes are full of blood. That's when the liver is happy. When the liver is not happy, your fingers and toes get cold, blood starts to back up and get stagnant, and then you don't have the free flow of energy anywhere, especially around the prostate. And if you've got all that turbidity and dampness at the same time, now you've got the recipe for a problem at the dam. So turmeric, I don't know how can you not talk about this plant? It's definitely the limelight plant of the day. The curcuminoids, sesquiterpenes, we love sesquiterpenes. Terpenoids are phenomenal. This plant has this yellow color, which we know is a big part of what makes it magical. I use turmeric in most cancer cases. And I'm just going to say something right now about the bioavailability of turmeric, because it's kind of a controversy. It's interesting because people always say that, hey, it's not well absorbed. And obviously, if we go back to Indian culture, you see that turmeric has been used as a spice in combination with curries. So it's always been given with spices and with coconut milk. Or milk or cow dairy, which makes it, a lipid-soluble situation. And to me, that makes a lot of sense. And traditionally, that's probably how it was best absorbed. So I don't think that we need to really put it into a lipid or, encapsulate it in a lipid, but it's probably smart to take it how it's always been taken, which is, in a fat. The guy who did a lot of the research into turmeric in cancer was at MD Anderson. His name is Bharat Agarwal. And you guys might know him. I don't know if you've met him, but really interesting guy. He spent 40 years studying turmeric, published tons of papers on it. He was part of the reason why MD Anderson did a long study of 1,000 different cancer patients taking turmeric in combination with chemotherapy. And I talked to him one day about the absorbability and such, and he said, it's funny because they did these studies about the pharmacokinetics and absorption of the material, and they would give the people the turmeric, and then they looked at their blood. I think it was actually animals, it was rats. And they didn't find the turmeric. They couldn't find the curcumin in the blood. So they thought, oh man, the absorption's terrible. And he said, but what they did is they took tissue samples of those animals. And the curcumin was already in the tissues. And he said the absorption was so fast that it went through the blood and into the tissues that they missed it. And that was from Bharat Agarwal. That was to me directly. So I take that as, having some bearing on something. But he also said that I bet you turmeric as a plant, as a whole root, chopped up, used in teas, used in foods, is just as good as taking your curcumin in a capsule. So I often make sure that people are taking whole turmeric powder, using the turmeric root, and take that in larger doses than just the curcuminoids. It's also, with all these therapies, cost is a big deal for people. It's very hard to keep up with these cancer protocols, with these Parkinson's protocols. It's really hard. So any way we can help our patients by not just falling down the trap that we're all in, it's just like, go to the capsule that has the label that's 6 times the cost of the material to start with. If we can help them, that's great. So I try. Like I was just saying, the whole turmeric is great. I love turmeric powder, but I do more teaspoon doses. And people can take it really well. Like People will have GI problems if they start taking curcumin. A lot of the dose escalation studies went 4 to 8 grams per day of curcumin. I can go quite a bit higher than that with turmeric. But those were studies that were done in combination with COX-2 inhibitors, in combination with chemotherapies, 4 to 8 grams. And you just got to build up slowly for a lot of people, and you do it with food, and just watch for GI disturbances. People get GI, they can get some pain, bloating, gas, cramping, diarrhea. So in Chinese medicine, this is a plant that promotes blood circulation to remove blood stasis. Okay? It's a warming plant, though. It's not this cold plant that just gets rid of heat in the body, which is where it's so interesting that it's it's the anti-inflammatory. Man, all these herbs are anti-inflammatory. So many of them are anti-inflammatory. It's just that turmeric has gotten a name to be this anti-inflammatory herb, and now everybody's just doing it in huge doses, and anybody thinks, oh, I've got some pain in my elbow, I'm doing some turmeric. Okay. That's the prescriber tradition again. Anti-prostate cancer. You just got to put the slide up because it's so cool. It just shows all the different pathways that are modulated by turmeric and curcumin. It's not worth going into in any depth in this context, but it's an amazing substance for sure. Green tea. This is one that a lot of human studies in green tea in China. Taking large amounts of green tea every day, drinking green tea has been shown to prevent a lot of different diseases. We talked about caffeine yesterday, so if you're a slow metabolizer of caffeine, watch out for that because it could be problematic. If you're a rapid metabolizer, you'll probably do pretty well with it. And it's the catechins in this plant, including other compounds like theanine and caffeine and theophylline and theobromine, the methylated xanthines, that all work together with the polyphenols and the flavonoids to make the whole plant like a magical creation of nature. It's something really beautiful. And it has huge benefits. And I have most of my cancer patients doing green tea. I like it in prostate cancer. I like it in combination with curcumin, selenium, lycopene, and grapeseed and skin. A lot of this, and it can be done, along the way as far as like we got to the vascular stuff, the insufficiency, the cardiovascular disease. It's great for helping keep the vasculature together. It protects the endothelium. 1 to 2 grams per day of powdered extract, 40 to 60% EGCG. It's better for your patients that are caffeine sensitive too. If it's more extracted towards the epigallocatechin gallate, the EGCG, it's a little bit better on them, a little easier for them if they're, if they get stimulated by caffeine. Some synergists, green tea and quercetin, another flavonoid that I love. I found an anhydrous source of quercetin also that's really cool. It mixes in water. It's quercetin I can dose pretty good with people, 2 or 3 grams a day for folks who get a lot of histamine reactions. You guys seen that MCAS syndrome, the mast cell activation syndrome? Quercetin's always a part of that for me. It just kind of shuts down some of the reactivity of a destabilized network where the person's reactivity, these little, almost like little mines in their body that are set up to react to certain, dangers are just set too high, and they blow up all the time and send out all this histamine and heparin and leukotrienes and all this other stuff, and we're trying to stabilize that system. That's very helpful, but quercetin has lots of other benefits as a flavonoid in protecting the body from damage. Combining turmeric with resveratrol, green tea with zinc, green tea and lycopene. So just kind of some data supporting the idea that if you put things together, we get more benefit than just individual things alone. Huang Qin, Scutellaria bicolensis, love this plant. This is the one for the guy I was describing who's really hot, who's red, who's got the excited, the liver is just pissed off, he's got red face and hypertension. This is a very cold and bitter herb, clears heat, dries dampness, disperses fire, expels toxins, stops bleeding, even stabilizes a fetus when the problem is due to kind of heat energy in the body. This is an herb that clears damp heat. So when we get that damp constitution that we described before, with all that turbidity, this is a way to help get rid of what occurs after a period of time with that dampness, which is a thing called damp heat. And damp heat often exists in the lower part of the body. It can be part of that prostate picture where there's damp heat, and the person will have more of a bigger pulse, a fuller pulse, an excess tongue picture. They'll have all these excess signs. You want to clear damp heat out of their body. This is a great herb. This is an exemplary herb from that category. This is very different than the formula I put up there, the shut the sluice powder, which is something for the deficient person, the cold, pale, wan, flabby type of person. That person is going to need that other formula. Okay? We're still treating the same thing, right? We're still working on the prostate, swollen prostate with urinary tract symptoms. Biomedical actions, antimicrobial, antipyretic, blah, anti-inflammatory, blah, 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 blah. So much good stuff. I can't just go on and on about this stuff. Wilgonin and bicoline, those are great compounds, all shown lots of benefit, lots of anti-cancer across the board. Love this plant. Medicinal mushrooms, we talked about this last night on our panel. Bioremediators. They're used in the environment. They suck up toxins. They do that in our bodies. They're great for clarifying the way the body communicates. And we talked about that the earlier slide. Remember the great Yu, the guy who built the channels to get rid of the water to save his kingdom from the flooding that was happening? That's what these guys do. Mushrooms help to guide fluids out of the body. They help to clear turbidity, get rid of dampness, which is a turbid type of fluid, and clarify the communication network. This is great for the immune system. So for me, aside from the fact that we've got all this research that says, hey, stimulates natural killer cells, improves T lymphocyte activity, all the stuff we see about immune modulation, for me, the immune system functions a lot better when the environment is clear, crystal clear, compared to when the environment is sticky and cloudy. When it's really cloudy, it's really hard to identify self and non-self. When it's crystal clear, it's real easy. So the mushrooms help us clarify what is self and what is non-self. Turkey tail, cordyceps, chaga, and reishi. Those are my top 4. I love those. All 4 of those mushrooms. In almost any cancer, I love those mushrooms. I was saying last night, chaga, very specific for melanoma with the betulinic acid. Reishi, really good in prostate cancer. It's one of my top 2 herbs with milk thistle. High doses of reishi. A good powdered extract, 4-to-1 to 15-to-1. It should be, all these mushrooms should be extracted, mycelium and fruiting body, and they should be extracted in traditional decoction. If there's going to be an alcohol portion to try and clarify the terpenoids and get the terpenes in there as well, that needs to be done in addition to the water extraction. Okay? All the data that's come out, all the research is on water extractions. A couple of extracts, PSK and PSP. These are polysaccharide extracts that have been popularized in Japan, become actually anti-cancer immunotherapies that have been approved in Japan for treating cancer. And they're used in combination with chemo and something called chemoimmunotherapy. I like to dose 3 to 6 grams a day of a good mixture of these. Sometimes I'll double that for people. Very clarifying, very easy to take. Can be a little bitter tasting, so again, mixing it, making it taste good. But if you're going to try to give somebody, a 6-gram dose per day, that's a lot of capsules. You're looking at, if you got 500 milligram capsules, that's 12 capsules of that one plant, at one of your therapies. So if you can give it to them in a powder, it's a lot better. This plant's another one that I really love, Hujiang, the tiger cane, Polygonum cuspidatum, the richest source of resveratrol that we have on the planet. Resveratrol, we found it's a phytoalexin. It's part of the antifungal network that the plant creates. So if you tried to grow the stuff in your backyard and started growing it over generations, you wouldn't have that resveratrol there. It needs to be in its local environment where the plant grew up, where it's interfacing with funguses and other predators, other things that it has to build resistance to. And resveratrol is one of the ways it resists being taken down by other infectious organisms. This plant has so many cool actions. Resolves phlegm, blood stasis, and heat toxins. Those 3 things in Chinese medicine are a big part of any cancer process and can be a big part of a lot of prostate cancer issues, especially once it's evolved beyond the stuff we've been talking about. Some more biomedical actions of resveratrol. I also have resveratrol as a powder, and I like to combine it with the Hujiang, though. I like to put the plant with the extract. I've been talking about that for a long time. If I could grow the plant in my backyard and make it make more resveratrol, that would be so cool. I could just isolate a plant and make it make the compound that I wanted. But that's really hard, and I don't have those resources. So I've been taking the plant compound and combining it with the whole plant to get a better effect between the two. And resveratrol, it's had a lot of kind of ups and downs in the literature, and people thought it was so great for anti-aging with telomerase, and that kind of got disproven, and it's been shown, it's got lots of different data on it, but again, nobody's done any big clinical human studies, so we don't know exactly. So I don't dose it super high. I like to do quarter teaspoons, half teaspoon doses. That's getting in the range of hundreds of milligrams in combination with other plants, and I'll put it right in a formula with other things. But you can see that it has a lot of different actions, normalizing gene expression, inhibiting platelet aggregation, ischemia. We talked about hypoxia-inducible factors, inhibits vascular cell adhesion molecules. It's just got a lot of different benefits, and it's something that we need to consider in all of our therapies. Nutrients for both of these pathologies with the prostate. I told you before, zinc is number one, right? The number one nutrient for the prostate. Tons of human studies with zinc and prostate health. Big help. I'm just going to go right through them. Lots of enzyme systems. Essential cofactor, just like we talked about magnesium yesterday with the heart. Essential cofactor today with zinc. Essential cofactor. Very important for testicular development, pituitary, thyroid, adrenals. Blocks dietary copper. We talked about that, how copper and zinc are on kind of a teeter-totter. They manipulate each other. Zinc dosing. I put a little slide in here that gives us some more details on dosing. Vitamin D. I mean, everybody talks about this in every talk. It's pretty much just vitamin D, right? But the idea is normalizing levels. And what I wanted to say about this earlier, aside from the fact that it can lower SHBG, right? That's one thing we talked about, right? If you've got a person and they've got too high of a binding globulin, their hormone is all being bound up, so they're not getting that anabolic effect from the hormone. How do we influence that? We talked about using urtica dioica root, right, as a way to modulate that binding globulin and free up some of their hormone. You can also use vitamin D as a way to do that. Just by normalizing their vitamin D, you increase their thyroid function. You'll have an impact on their blood sugar handling, their insulin, all these different endocrine factors that will all play together to help the sex hormone binding globulin normalize. And one more note on that is just that when people have more estrogen, more insulin in their bodies, more insulin resistance, they're going to have more binding globulins present too. It's going to bind up their hormones. So vitamin D, the thing I was going to say is that it's really important that we look at both their 25-hydroxycholecalciferol and their 1,25-dihydroxycholecalciferol. Because in diseases where the immune system is called to upregulate, you'll find that conversion rates vary. And you'll find that a person can have their 25-hydroxy level looked at, and it might be totally normal, or it might be low, or it might be a little bit on the high side. And if you don't look at their converted form, you don't see what's actually happening. It's just like with these hormone metabolites, it's a vitamin D metabolite. So in a person who has a Lyme infection, oftentimes their vitamin D 25-OH, their storage form, might be 35. But then you look at their 125 and it might be 110. It's because we know now that there's a whole system called vitamin D macrophage activating factor, which is also known as GC-MAF. This is a way to inhibit an enzyme called nagalase in cancer cells that's been explored pretty much, pretty indefinitely right now, deeply in some circles, but hard to enact in our clinics right now because of material problems. But we can influence the immune system by affecting that macrophage activating factor, and vitamin D is the essential piece of that puzzle. And we need to have that 125 form in order to activate our immune system. These are our macrophages. These are the guys that clean up all the stuff we want to get rid of in our bodies. So make sure you look at both of those levels. And we've been talking about vitamin K a bit, and vitamin K is the thing we can give to help normalize those levels in a patient where you can't understand where it's coming from. If it's some kind of a co-infection, a problem that's underlying, if it's cancer, we don't know what it is, vitamin K will help to balance vitamin D levels between the storage and active forms. Vitamin K also is essential to give with vitamin D because it'll help to get the calcium on the bones and out of the blood vessels. I talked about that yesterday, how important that is. Somebody here said, poor prostate health is essentially a vitamin K insufficiency disorder. There was a study that came out that was really big on vitamin K. And it's funny because to me, it goes back to the story I told you guys about Gattin-Gorin, right? And about the problems that are happening with vascular insufficiency in bipedal men who have long interspermatic veins whose backflow valves blow out, right? We're all familiar with that story now. You guys got that from earlier, right? So imagine, we talked about what could damage those valves, what could lead to that problem is part of it, aside from inflammation, oxidative damage, the breakdown of the endothelium, is calcification. And calcification of the vessels in our bodies leads to problems with the valves. The valves don't work well when the vessels are hard. So vitamin K can actually help to correct those valves by increasing the flexibility of the blood vessels. So the K moves out of the vessels and goes onto the bones. The blood vessels start working again, and less of that free testosterone gets shifted over through the differential vein into the prostate gland. You guys follow me on that one? So this is it's just an interesting way to get at that problem that we're not quite sure how much we're going to be able to affect it without using the Gattin-Gorin method, but I think we can. If we combine vitamin K, reversing arterial calcification and venous calcification too, we might be able to do some work in combination with those other vascular tonics, the vascular astringents that we talked about. Beta-cytosterol, this is a plant cholesterol, has a really good effect also in BPH. A lot of it's found in a lot of different plants. It's been put in a lot of different things like butters and margarines and things to try and help decrease heart problems, to kind of help cholesterol and atherogenesis. It's also shown a lot of good benefit in BPH. Chrysin is a great natural aromatase inhibitor. They're supposed to be, oh, right there, yeah, picture, passion flower. It's found in a number of things, but passion flower is a great source. 500 to 1,000 milligrams a day. It will inhibit the conversion of testosterone into estrogen via aromatase. That's our best natural form. Combine it with green tea and quercetin for even better results. So these are people that have that estrogen to testosterone ratio. I said that's skewed. And if you're giving someone testosterone, if you're the kind of person who likes to do hormone therapy, then make sure you use chrysin along with your hormone therapy so that that testosterone doesn't become estrogen. So a lot of bodybuilders do this. They take testosterone to get stronger, and they're always online looking for chrysin because they want to inhibit that estrogen buildup. So vegetables to the rescue, lycopene. Everybody knows about that. It's great in a formula. I don't really use it as a solo thing. I just have people eat tomato if they don't have problems with nightshades. We can have, it's cooked tomatoes though. It's not raw, so tomato sauce. If it's in a formula, 20 to 30 milligrams a day, it's been shown to, have a powerful effect on outcomes in BPH and prostate cancer. It reduces PSA, mostly through an antioxidant mechanism. I3C, DIM, and isothiocyanates. These are your broccoli sprouts, your broccoli seeds. And it was a good thing that broccoli itself was thought to be a good source of isothiocyanates originally. And then what happened was the researchers who were doing the studies on broccoli actually found that they didn't have enough broccoli to do the studies, and all their broccoli was in sprouts. So they said, well, let's just do it with sprouts. So they took the sprouts, and they did the study with sprouts, and they were like, oh my God, there's like 10 times as much isothiocyanates in here as there was in the broccoli. And they thought, well, why don't we check the seeds? And the seeds had even more. So now we use broccoli seeds as a way to get these compounds, isothiocyanates, from these sprouts. And cabbage sprouts are another great source. Diindolylmethane methane is on here. This is also found in these compounds. Diindolylmethane methane you can use as a way to help keep estrogen from becoming what's called a 16-hydroxyestradiol, 16-hydroxylation, or hydroxyestrone. We want the estrogen to go down the metabolic pathway that results in it being hydroxylated at the second carbon, not the 16th. And DIM does a good job of helping that happen. So some dosing additions, I threw this on kind of at the end. Vitamin K2, and remember it's K2. It can be either the MK4 or MK7. Either one is fine. K3 is a different thing. That's metatetranone. That's a synthetic vitamin. That's not what we're using. And K1 is found in nature and can be converted into the body into K2, but not nearly as readily. It's a fat-soluble vitamin. Yep. Most of the stuff will come in, I've got one that I like to use that's a liquid, and then I've got some other capsules that are also good too. But yeah, it's anytime you want to take a fat-soluble vitamin, take it with fat. Yep. Vitamin A, vitamin D, vitamin K, vitamin E, yes? At least 150 to 300 micrograms in general, just like as a simple way to go. But then if you really want to start reversing arterial calcification and things, much higher. I like to do 5 milligrams as a minimum. And then the research out of Japan that shows the best, it's really the best therapy I've seen for osteoporosis is 45 milligrams of vitamin K2 every day. And I've seen it in practice work really well. Some people are like, wow, 45 milligrams. But it's, the RDA is about 150 micrograms. So you're getting a little bit higher than RDA. RDA is an interesting concept. Sulforaphane, that's kind of one of the main glucosinolates from the broccoli seeds and cabbage sprouts. Wonderful effects. It stabilizes the genetic mutations associated with P53 gene, which is the gene that is like a checkpoint to make sure that gene transcription is occurring normally. Some additional therapeutic strategies. We saw the estrogen mimics, right? Our story about plastics, pesticides, things that disrupt the way estrogen is metabolized in the body. Support the liver function. Use liver formulas. Use liver herbs. Use herbs for the gallbladder. Do juices, celery, green juices, lemon and lime. Use lots of good green foods. Sometimes a little bit of green apple. I don't do a lot of juices with beets and carrots because they're too sweet. Burdock root, turmeric, ginger, radish, the daikon radish. These are all really good things. You can have people juice and work on their livers that way. Alteratives, these are herbs that are really helpful. Things like I had on the board the other day, mayapple. Things that kind of alter the way that the function of the liver helps to get the body to metabolize and rid itself of toxins. Adaptogens, I put schizandra up here. It's such a great plant all around, very hepatoprotective. You can do adaptogens. They will just help the body deal with the stress of the endocrine disruptors. Resveratrol, the sulforaphane we just talked about, diindolylmethane and calcium D-glucarate, which is also an estrogen regulator as well. These are just some simple ideas to kind of help you with the fact that we know everybody's going to be affected. Even chlorine is an estrogen disruptor, an estrogen mimic. So you go in the swimming pool, you go in your shower. This is for chronic venous insufficiency. I got those 4 herbs, the collinsonia, the horse chestnut, butcher's broom, witch hazel. Those are all up there for you guys to think about. A formula that basically is all those 4 in a tincture is a great way to go. And you can do teaspoon doses. Sometimes I'll give collinsonia as the chief herb for vascular type stuff, especially if it's hemorrhoids. But if it's spider veins, if it's esophageal varices, if you suspect that it's internal spermatic vein varices, this is a great formula to use. I've been kind of adding this in with my prostate cancer guys, trying to help get them some support along with the stuff we said, the dietary and lifestyle changes in the way we sit or stand. Adding the polyphenols and the anthocyanins, the berries, the vaccinum, things like the hawthorn we saw yesterday was such a great antioxidant. It protects the blood vessels as well. We've got vitamin K in here as a way to help soften the arteries. All these things can help make those blood vessels work better, and hopefully we can be very preventive in our approach as well. So I'm already starting to do all this stuff because I'm suspecting that I will be another one of the men who will have problems. I did this already. I went the wrong way. Good. Urine pH. I love doing pH. I have people measure pH 3 times a day, 4 times a day, urine pH. Don't get tricked into people saying, you got to alkalize your blood. How do you alkalize your blood, guys? You don't. Your blood stays at about 7.4. That's it. It's not going to change. You can get down to 7.2. You'll be okay. But you start getting below that, and you're going to start to get in trouble. So you're not alkalizing the blood. You're adding buffer. The body has to constantly tightly control the blood pH. And in order to do that, it's got to get materials from the tissues. And the tissues can either be enriched with lots of buffer that are acidic or lots of buffer that's basic. So in a lot of people, we have something called chronic metabolic acidosis, which is basically stress on the system that's taking all their alkaline buffer and using it to maintain correct pH in the blood. When that happens, the person's depleted. Other tissues that should have lots of electrolytes get depleted. So watch their urine pH. We're looking for a little bit of higher than normal, especially in prostate cancer. I like to put it over 7. Not up to 7.5 or 8, but right up there around 7 is a really good place to be. Some men, you'll see they're at 5.5. Good outcomes in prostate cancer, definitely with keeping the pH a little bit higher, even from Stephen Strum, the guy who developed the nadir for androgen deprivation therapy, who lives in Ashland, Oregon. He's a urologist who I've worked with for years. He even does the urine pH stuff, and he finds it to be very effective. Helps with a lot of the symptoms. I use a product called Trisalts. It's carbonates of magnesium, potassium, and calcium. Carbonates aren't absorbed really well, but they will create some of that buffer for you. Get rid of acidic compounds. But baking soda is what a lot of people use. And they use it for reducing acid in the stomach. You can use baking soda. But remember, this is sodium chloride, high amounts of sodium. And too much sodium over time is real hard on the kidneys and eventually can affect your potassium levels. You have to take more potassium. So just do the trisalts, the carbonates of these other cations. It works better. My dosage is really between 1/2 and 1 teaspoon once to 2 times a day. Yep. And the trisalts is you want to get a pretty good dose. You really want to get that pH up and hold it up. And the first morning urine isn't always the best one. Normally I wait till the second one, and then I have them do it in midday, and then later in the day. And if they're ambitious, do it 4 times a day. I have them bring in a sheet, over a course of a few days or a week. This is a really cool tip for people who did do radiation. Trental's pentoxyphylline. Pentoxyphylline is a theophylline derivative. It's really good. It changes the shape of the blood vessels, the capillaries, and allows the blood to flow into areas that are fibrotic. So with radiation-induced fibrosis, this combination right here is like magic. Trental, pentoxyphyllene, 400 milligrams BID, and vitamin E, 1,000 milligrams. And that should be the full spectrum vitamin E. That's the pentoxyphyllene. It's a medication. It's a prescription drug. It's a synthetic theophylline, which comes from green tea. Yep. It's really unique, though, in its action. So some controversies in prostate cancer. There's lots of them. I just was going to say a quick thing about Avodart and Proscar. People came out and said, hey, Avodart and Proscar, they cause people to have more aggressive disease. 10% of men who take these drugs get more aggressive disease. They get more prostate cancer. And what happened was Life Extension came out and did a big rebuttal against this. It was really beautifully done. And they showed that Avodart and Proscar actually do reduce the size of the prostate gland. They shrink the prostate considerably. 28% was their average. So imagine, you're going in with the needle and you're poking around. You just reduce the gland by 28%. Well, the chances that you're going to hit the prostate cancer are a lot higher. Do you understand what I'm saying? Big volume, small needle, hard to hit. Smaller volume, same needle, easier to hit. Also, a lot of data actually with Avodart and Proscar shows that it actually reduces aggressiveness of prostate cancer and does inhibit prostate cancer. Like I said before, dosing is key. I often recommend to a patient that they talk to their doctor, their urologist, about doing half of the dose or even less. Because the full dose of Avodart gets your dihydrotestosterone to almost nothing. And like I said, there are other downstream metabolites that are important that we don't want to miss. You don't want to just give up that, like I said before, you don't want to just get rid of one growth factor entirely. You create an environmental pressure that leads to mutational changes. We can avoid that. Let there be a little bit and then modulate it with plants. Avodart also is a much better agent on the whole because it has a long half-life, 3 weeks. 3-week half-life. Proscar is a few hours. So Proscar, you got to dose. Avodart, guys can do it every third day, every fourth day, every other day. The main side effect I see is people will get erectile problems, just a little bit of erectile dysfunction. Testosterone levels will decline a little bit when they get the dose too high. So you've got to find just the right balance. And you can follow this in men really nicely and have a real positive effect on their outcome. Red meat and prostate cancer. Bunch of stuff came out recently on saying that red meat causes prostate cancer, right? You eat red meat. You tell everybody you got to avoid red meat. Guys, I'm sorry, but I personally don't think that red meat is the cause of cancer. I think human beings have been eating animals since we were born on this planet, as long as we've possibly been here, or in whatever context, in whatever way you believe in it. But if you don't identify what type of red meat you're eating, you just missed all the variables. Not only are the people who eat more meat tending to eat all these other things, like eating fewer meats, vegetables, and fruits that are protective, smoking more cigarettes, eating more processed flour and sugar, but also they're eating meats that are, first of all, overcooked. What does that mean? Polyaromatic hydrocarbons, heterocyclic amines. You overcook meat, what do you get? You get toxins. So we didn't eat cooked meat for most of the time we've been on this planet. So also look at the meat people are eating. These are coming from caged feeding lots, okay? These are animals that are tortured. These are animals living under stress their entire lives. Then they're all getting infections, so they're all getting antibiotics. Then they're all getting injected with hormones to make them fat so that we can eat them. Then they're getting fed GMO grains, and then they're getting fed their own brains and their own bones. What is the problem here? It's not red meat's fault, okay? It's our fault. So that's my take. Slightly passionate about it. Selenium and vitamin E also got accused of being problems in prostate cancer. I'll just say they use synthetic vitamins for the studies, okay? Don't use synthetic vitamins. We use real vitamins. Vitamin E, combine it with selenium. Great stuff. If you're going to use DHEA, I still recommend you do the same stuff. Use chrysin, use green tea, use quercetin, use aromatase inhibitors. If you need to, use aromatase inhibitors that come from the pharmaceutical realm. If you're going to do high doses of hormones, control them. Make sure you help the people metabolize them the right way. And there we are, the man in the maze. We got it.